Today we will go about the subject of fluid and electrolyte disturbances. So, this of course is going to involve explanation about the composition of body fluids, uh, the regulation and water disturbances, sodium disturbances, and then we will follow up with add-on videos of potassium disturbances, and then finally calcium disturbances. So for starters, the human body is composed of 55% fluids in the female and 60% fluids in the male counterpart. These fluids are further divided into either intracellular fluids or extracellular fluids. The intracellular being two-thirds of that, and then only one-third is the extracellular fluid. Uh, if we look at this diagram here, we see that the extracellular fluid is further subdivided into interstitial fluid and plasma. The plasma is the fluid that courses through the veins and arteries with the circulation. Now, uh, according to Stirling law, the fluid moves from the capillary towards the interstitial fluid into interstitium and tissues within the capillaries, and that's because the transcapillary hydraulic pressure exceeds the corresponding oncotic pressure uh, gradient of between the blood in the capillary and the tissue, and thereby favoring a movement of a plasma ultrafiltrate into the extravascular spaces. The return of this fluid is carried on via the lymphatic flow. Before we dive deeper into the water and solute disturbances, we have to define some terms. First, we have osmolality, and it's defined as the solute or particle concentration of a fluid. We express osmolality as milliosmoles per kilogram of water, and the major ECF particles are sodium and its accompanying anions, chloride, and bicarbonates, whereas potassium and organic phosphates esters such as ATP, keratine phosphates, and phospholipids are the predominant ICF osmoles. In other words, these are the solutes that determine the water gradient across cell membranes. So the potassium and the phosphate esters favors uh, water gradient inside the cells, while sodium and its anions, the chloride, so sodium chloride and sodium bicarb, these are the solutes that determine or make the osmotic power to draw water from the tissue toward the vessels. Solutes that are restricted to the ECF or the ICF determine the tonicity, and that's why we say this solute is isotonic, hypertonic, or hypotonic. It's in regard to its sodium chloride or sodium concentration related to that of the normal human plasma concentration. And then certain solutes, particularly urea, do not contribute to water shifts across most membranes, and this thus known as ineffective osmoles. Why? Because they uh, to get transported across membranes easily, so they would not determine the tonicity of a fluid because they already move across the gradient with the water. So, starting with the water balance, vasopressin secretion, water ingestion, and renal water transport collaborate to maintain a human body fluid osmolality of between 280 and 295 milliosmoles per kilogram. Vasopressin is synthesized in the magnocellular neurons within the hypothalamus. The distal axons of these neurons project to the posterior pituitary, which is also known as the neurohypophysis, from which AVP is released into the circulation. Osmoreceptors in neurons activation leads to the release of AVP and thirst, which also means that the AVP secretion is stimulated as a systemic osmolality increases above a threshold level of 285 milliosmoles per kg, above which there is a linear relationship between osmolality and circulating AVP. Thirst and this water ingestion are also activated at 285 milliosmoles per kg, beyond which there is an equivalent linear increases in the perceived intensity of thirst as a function of circulating osmolality. So, in other words, the human body maintains at all times an osmolality of 280 to 195 milliosmoles per kg. And this is maintained by some neuroreceptors called osmoreceptors in neurons, the activation of which activates the magnocellular neurons in the hypothalamus, which projects its axons into the neurohypophysis, and then it increases the AVP, the vasopressin, which we will shortly talk about its effect on the renal tubules and how it increases water resorption and decreases osmolality. Now, going back to the text, blood volumes and blood pressure also are direct stimuli for AVP release and thirst. So that's why when we see a patient with a gunshot wound and he's bleeding, he's going to be very thirsty and more often than not demands to drink water, and we usually prevent that because he's going to need, or he or she is going to need a surgery, maybe post hastily. So ECF volume strongly modulates the relationship between circulating osmolality and AVP release, and we're going to see in a minute how it affects it in a chart or in a diagram. And the AVP has a half-life in the circulation of only 10 to 20 minutes, and that's why the human body can do the fine-tuning of keeping the osmolality in this tight range between 280 and 295. Non-osmotic stimuli, including nausea, intracerebral angiotensin 2, serotonin, and multiple drugs, also affect either the response or the release of AVP and thirst mechanism. In this diagram, we see the ECF volume as a modulator of the linear relationship between plasma osmolality and plasma AVP secretion. We see in the normal state, in the euvolemic state, there is a linear increase of after about 285, that the more osmolality increases, the more plasma AVP will follow. With that, more thirst and water ingestion. What other modulators we have? The modulator we are talking about is the ECF. We see in the case of hypovolemia, this linear relationship starts a bit earlier at about 270. The more profound the hypovolemia, the more profound is going to be the drawback in this line. So it can start at 265 to 60, or can start maybe if the hypovolemia is not that profound at a higher range. Again, we see hypervolemia modulating that relationship and decreasing the linear association between plasma AVP increase and plasma osmolality, dragging it forward, so less AVP is increased, secreted with increases in plasma osmolality. Now we have talked about the factors that causes an increase in the AVP secretion and what modulates that secretion. Now we are going to talk about the effect of the AVP on the renal tubular cells and how that ultimately affect the water balance and osmolality. So AVP acts on renal V2 type receptors in the thick ascending limb of Henle and the principal cells of the collecting duct. If we look to the diagram on the right, we see the thin descending and the thick and the thin ascending and then the thick ascending loop of Henle. This is the loop of Henle, and here we have the distal convoluted tubule, and finally descending in this picture to the right is the collecting duct, and this is the place of action, the place of the V2 receptors that the AVP works on. So the effect of the AVP inside the cell is that it increases intracellular levels of cyclic AMP and activating protein kinase A dependent phosphorylation of multiple transport proteins. And this is the secondary messenger mechanism. And what it ultimately does to affect the clinical picture we have is that it increases the activation of sodium chloride and potassium uh, transporters in the thick ascending loop of Henle. And this is a key participant in what is called the countercurrent mechanism. And basically, the countercurrent mechanism is the absorption of water into the this intermedullary inner medullary interstitium, which is very concentrated. Its osmolality reaches about 1200 or even more. And why this medium is so much rich in osmolarity? It's because of these transporters in the thick ascending loop of Henle, and also in the collecting tubules. So what happens here is that the V2 receptor is going to affect some cyclic AMP increases, and pKa, protein kinase is a phosphorylation. It activates the sodium, potassium, and chloride co-transporters, leading for these solutes to go to the inner medullary medium, thus dragging more water in as the collecting tubes or collecting ducts dip downward through this highly concentrated medium. The countercurrent mechanism ultimately increases the interstitial osmolality of the inner medulla of the kidney, driving water absorption across the renal collecting ducts. However, water, salt, and solutes transport by both proximal and distal nephron segments also participate in the renal concentrating mechanism. So, it's not just the loop of Henle. You also have sodium chloride channels in the distal convoluted tubules, also in the proximal convoluted tubules. Now, so water transport across apical and basolateral aquaporin 1 water channels in the descending thin limb of the loop of Henle is this involved, as is passive absorption of the sodium chloride by the thin ascending limb via apical and basolateral ClCK1 chloride channels and paracellular sodium transport. Under antidiuretic conditions with increased circulating AVP, the kidney reabsorbs water filtered by the glomerulus, equilibrating the osmolality across the collecting duct epithelium to excrete a hypertonic concentrated urine of osmolality of up to 1200 milliosmoles per kg. The absence of circulating AVP insertion, aquaporin 2 channels, and water absorption across the collecting duct essentially abolished, resulting in a secretion of hypotonic dilute urine. The osmolality is as low as 30 to 50 milliosmoles per kg. Now, abnormalities in this final common pathway are involved in most disorders of water hemostasis, such as reduced or absent insertion of active aquaporin 2 channels into the membrane of the principal cells in the cases of diabetes insipidus. And an interesting information is that the kidney filters some 25,200 millimoles per day of sodium, and this is equivalent to 1.5 kilogram of salt, which could occupy roughly 10 times the extracellular space. 99.6% of filtered sodium chloride must be reabsorbed to excrete 100 millimole per day. Many changes in the renal sodium chloride excretion will thus have significant effects on the effective circulating or the extracellular fluid volumes, leading to edema syndromes or hypovolemia. Now, if we look to the diagram on the right, we have the collecting duct principal cells, and in this we see the lumen, the tubule or lumen in the right. This is where the urine is formed by concentrating of the ultrafiltrate, and we have the aquaporin 2 channels. The aquaporin 2 channels is activated via the AVP or the ADH hormone, the vasopressin. What it does is it increases cyclic AMP, which activates phosphokinase A dependent phosphorylation enzymes, which leads the aquaporin 2 to lodge into the lumen. This allows free water to flow the principal cell in the collecting duct from the lumen towards the interstitium and then reabsorbs back to the circulation and the blood. Now, if there is a failure of or there is a deficiency of this aquaporin 2 with an adequate amount of AVP, we call this nephrogenic diabetes insipidus. And basically, what happens is that we don't have this transport mechanism, and thus the uh, the urine carries on with a large amount of free water, leading to a low osmolality urine. In the antidiuretic state, we have a lot of these aquaporins allowing to absorb almost all the water and equilibrating the interstitium uh, with the urine, leading to a very dense urine of 1200 milliosmoles. Approximately two-thirds of filtered sodium chloride is reabsorbed by the renal proximal tubule via the both paracellular and transcellular mechanisms. The thick ascending loop of Henle subsequently reabsorbs another 25% to 30% of filtered sodium chloride via the apical furosemide-sensitive sodium chloride, sodium potassium 2 chloride cotransporter. The adjacent aldosterone-sensitive distal nephron, comprising of the distal convoluted tubule, connecting tubule, and collecting duct, accomplishes fine-tuning of renal sodium chloride excretion. The thiazide-sensitive apical sodium chloride cotransporter of the distal convoluted tubules reabsorbs 5 to 10% of filtered sodium chloride. The principal cells in the connecting tubules and the collecting duct reabsorbs sodium via electrogenic amyloride sensitive epithelial sodium chloride channels ENACs. Chloride ions are primarily reabsorbed by the adjacent intercalated cells mediated by the SLC26A4 anion exchanger. Also, there is effect of angiotensin 2, which activates proximal sodium chloride reabsorption, as well as other hormones such as adrenergic receptors under the influence of renal sympathetic innervation. If we look to the diagram on the right, we see the beta intercalated cells and the principal cells. The effect of beta intercalated cells is the absorption of a chloride and in exchange of HCO3, and that's via the SLC26A4. And the principal cells, what it does is the absorption of the sodium through the ENaC channels and excretion of sodium. Of note, these ENaC channels, the expression of them into the luminal surface is governed by the aldosterone, which has a receptor on the interstitium surface, and also that the sodium absorbed into the principal cells is exchanged for potassium. So a block of either the ENaC channels or of aldosterone is going to subsequently cause a hyperkalemic state. We also see that the principal cells has aquaporin 2, 3, 2, 3, and 4 channels responsible for the reabsorption of a free water into the interstitium and concentrating the urine, and these are controlled by the V2 receptor of the AVP hormone. Now we will start with our first water disturbance, which is hypovolemia. And hypovolemia is actually a disturbance of, it is most appropriately termed a sodium problem. So whenever you think about the water disturbances or hypo and hypernatremia, always think that what changes the volumes are the sodium, but it appears normal in the lab results. And what changes the sodium concentration, being hyponatremia or hypernatremia, is usually not the sodium transporters and sodium abnormalities, it's actually the water disturbances. So we will first talk about the causes of hypovolemia. Hypovolemia is defined as the true volume of depletion or hypovolemia. It generally refers to a state of combined salt and water loss, leading to a contraction of the extracellular fluid volume. The loss of salt and water may be renal or non-renal in origin. Some of the renal causes include osmotic diuresis, such as mannitol, glucose, or urea, and that's why patients with diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome will have a high hypo will be dehydrated and will be in a hypovolemic state because the glucose acts as osmotic diuretic. Urea is another cause. Diuretics by itself, such as loop diuretics, they are the most common uh, uh, diuretics that is implicated in hypovolemia. Drugs, other drugs like TMP, the trimethoprim, because it's anphentamide, they inhibit distal tubular sodium reabsorption through the amiloride sensitive ENaC channels. Hereditary defects such as diabetes insipidus, nephrogenic, or central. Mineralocorticoid deficiency like adrenal insufficiency. And tubulointerstitial injury that occurs in interstitial nephritis, acute tubular injury, or obstructive uropathy can reduce distal tubular sodium chloride and or water absorption. And diabetes insipidus has less effect on the effective circulating volume, the diabetes insipidus. Extrarenal causes, uh, fluid loss from the gastrointestinal tract and respiratory system. Uh, these account for evaporation of water from the skin and respiratory tract, account for 500 to 650 ml per day in healthy adults, and these numbers actually help us with our estimation of fluid status and replacement in healthy individuals or even in disease patient when we try to manage their fluid status. Daily fecal loss is only about 100 to 200 ml per day. And third, spacing is another important extrarenal renal cause of decreased extracellular fluid volume. This occurs in sepsis syndrome, burns, pancreatitis, nutritional hypoalbuminemia, and peritonitis. Now, in the text, I have put only the examples about these numbers. The extrarenal causes can include anything from GI bleed, diarrhea, vomiting, and etc. Diagnostic evaluation of hypovolemic state. Symptoms of hypovolemia are non-specific and include fatigue, weakness, thirst, and postural dizziness. More severe symptoms and signs include oliguria, cyanosis, abdominal and chest pain, and confusion or obtundation. Signs of hypovolemia include a decreased jugular venous pressure, orthostatic tachycardia, which is defined as an increase of 15 to 20 beats per minute upon standing, and orthostatic hypotension, which is a 10 to 20 millimeter mercury drop in blood pressure on standing. Blood urea and creatinine increase. Severe hypovolemic shock may develop in lactic acidosis with elevated anion gap. Urine sodium concentration is typically less than 20 millimoles in non-renal causes of hypovolemia, with a urine osmolality of more than 450 milliosmoles per kg. There is also an increase in plasma potassium concentration. And patients with hypovolemia and hypochloremic alkalosis due to vomiting, uh, diarrhea or diuretic will typically have a urine sodium concentration of more than 20 millimoles and urine pH of more than 7 due to the increase in the filtered HCO3. And the urine chloride concentration in this setting is a more accurate indicator of a volume status with a level of less than 25 millimoles suggestive of hypovolemia. To reiterate on this point, if you suspect a patient having a hypochloremic cause of hypovolemia, and by ABG this patient has an alkalosis, then do not seek sodium in the urine. To assess his hypovolemic status, seek chloride. A decrease in a chloride excretion is expected. Why? Because he's already losing much chloride through vomiting. Sodium will increase in its losses to just adjust to the sodium chloride ratio in the blood. The urine sodium concentration is often more than 20 millimoles in patients with renal causes, and this is obvious because what causes them to have hypovolemia is the failure of uh, kidney to reabsorb sodium and this to maintain its volume. Treatment of hypovolemia is usually isotonic normal saline of 0.9% normal NaCl, which has 154 uh, millimoles of sodium. It is the most appropriate resuscitation fluid for normonatremic or hyponatremic patients with severe hypovolemia. Hypernatremic patients should receive hypotonic solution consisting of 5% dextrose if there is has only been a water loss, or a hypotonic saline, half or quarter normal saline if there has been water and sodium chloride loss. Patients with bicarbonate loss and metabolic acidosis, as occur frequently in the area, should receive intravenous bicarbonate either in isotonic solution, 150 milliequivalent of sodium bicarb in 5% dextrose, or more hypotonic bicarbonate solution in dextrose or diluted saline. Sodium disorders, as we have mentioned earlier, that problems with hypovolemia and hypervolemia are usually problems of the sodium reabsorption, while the hyponatremia and hypernatremia termed sodium disorders are actually, in fact, a water hemostasis problem. So, sodium concentration is caused by abnormalities in water hemostasis, leading to a change in the relative ratio of sodium to body water. Water intake and circulating AVP, a defect in one of them or both of them usually causes hypo or hypernatremia. In contrast, abnormalities in the sodium homeostasis per se lead to a deficit or surplus of whole body sodium chloride content, a key determinant of the extracellular fluid volume and circulatory integrity. Therefore, a key concept in sodium disorder is that the absolute plasma sodium concentration tells one nothing about the volume status of a given patient, which furthermore must be taken into account by the diagnostic and therapeutic approach. So, as to say, if you see a patient with a sodium of 150, another patient of 125, this doesn't mean that this patient has more volume than that patient. It tells you nothing about that. It just tells you that the ratio of the sodium to body water is greater in the patient with the 150 sodium reading and less with the patient with 125. Hyponatremia is defined as a plasma sodium concentration of less than 135 millimole, and it's a common seeing. It's found in about 22% of hospitalized patients, and it happens due to an increase in circulating AVP and or increased renal sensitivity to AVP combined with an intake of free water. There is three groups of patients with hyponatremia depending on a clinical history and volume status, and we subdivide the hyponatremia into these three groups, which are hypovolemia, eovolemia, and hypervolemia. Now, the first thing we want to know when we approach a patient with hyponatremia is to know his fluid status, and we assess fluid status by measuring the JVP, auscultating the chest, examining for edema, examining the abdomen for ascites, maybe checking the membranes and blood pressure also. Our first group of causes of hyponatremia are the hypovolemic hyponatremia, and in this case there is a loss of total body water, but a more severe loss of total body sodium. And the hypovolemic hyponatremia is subdivided into two main causes: the renal losses and the extrarenal losses. And the way to differentiate between the two is simply by measuring the urinary sodium excretion. So in a patient with an extrarenal cause, we would expect that the renal is doing its job just fine and it's reabsorbing sodium, so the urinary sodium is less than 20 millimoles. If not, if the kidney is the cause, then the urinary sodium excretion is going to be more than 20 millimoles. Now, for the extrarenal causes, it is the same as the general hypovolemia: vomiting, diarrhea, third spacing of fluids, such as in burns, pancreatitis, or trauma. The renal losses include diuretics, excess mineral glucocorticoid deficiency, salt losing deficiency, bicarbonaturia with renal tubule acidosis and metabolic alkalosis, ketonuria, osmotic diuresis, cerebral salt wasting syndrome. The eovolemic causes, there is no edema and there is slight increase in the total body water with the same total body sodium, and we would expect the urinary sodium to be more than 20, because this is also caused by some sort of renal abnormalities, and these causes include glucocorticoid deficiency, hypothyroidism, stress, drugs, and syndrome of inappropriate antidiuretic hormone secretion, SIAD. And finally, we have the third subdivision, which is the hypervolemia, and in this case, there is a greater total body water increase relative to total body sodium, and also we differentiate it by being a renal cause or a non-renal cause by the same way. If there is more than 20 millimole of sodium excretion, then we look for acute or chronic renal failure. If there is less than 20 millimoles of urinary sodium excretion, then we look for other causes such as nephrotic syndrome, cirrhosis, or cardiac failure. Now, to explain more in detail about the hypovolemic hyponatremia, hypovolemia causes a marked neurohormonal activation, increasing the circulating level of AVP. And this increase in the circulating AVP helps to preserve blood pressure via vascular and baroreceptor V1A receptors, and increase in free water reabsorption via the renal V2 receptors. Activation of V2 receptors also can lead to hyponatremia in the setting of increased free water intake, because as we have learned earlier, that the modulation of thirst and AVP is done by the extracellular fluid volume. Now, the non-renal causes of hypovolemic hyponatremia included gastrointestinal loss, such as vomiting, diarrhea, tube drainage, insensible loss, such as sweating and MERS. Sodium concentration is typically less than, the urinary sodium concentration is typically less than 20 millimoles. And these patients may be clinically classified as eovolemic, with only the reduced urinary sodium concentration to indicate the cause of their hyponatremia. A urine sodium concentration less than 20 millimoles in the absence of a cause of hypervolemic hyponatremia predicts a rapid increase in plasma sodium concentration in response to intravenous normal saline. So saline therapy thus induces a water diuresis in this setting as circulating AVP levels plummet. And this is evident clinically when we have a patient who has been vomiting or in diarrhea, and we see that its sodium level is decreased. And when we start IV fluids, our first sign of this patient improvement is that he's have a urine output, an increase in urine output, a lighter color of urine, and we might falsely think, because yes, we are giving him fluid, so he's excreting this fluid. No, it is an hormonal effect. We are blocking the secretion of AVP by re-gauging the osmoreceptors back to its 285 range by removing the modulation of the hypovolemia of the ECF. And so we see the patient urinating, and it's a sign of improvement due to the block of AVP secretion. Now, of course, we have to reiterate the point that in cases where we have hypokalemic alkalosis, sodium urinary concentration may be more than 20 millimoles, so we have to look for urinary chloride excretion. Renal causes of hypovolemic hyponatremia is an inappropriate loss of sodium chloride in the urine, leading to volume depletion and increase in circulating AVP. Urine sodium concentration is typically more than 20 millimoles. A deficiency in circulating aldosterone and or its renal effects can lead to hyponatremia. A primary adrenal insufficiency and other causes of aldosteronism, hyperkalemia, and hyponatremia in a hypotensive and or hypovolemic patient with high urine sodium concentration much greater than 20 millimoles should strongly suggest this diagnosis. So we see a patient with hyperkalemia, hypotension, and hyponatremia. We should look for a deficiency in adrenal hormones, particularly, of course, the cortical mineralocorticoid of aldosterone. Other renal causes include salt losing nephropathies, which may lead to hyponatremia when sodium intake is reduced due to impaired renal tubular function. Typical causes include reflux nephropathy, basically a distal obstruction or an abnormality of the ureters, which causes the urine to backflow back into the kidneys and causes abnormalities within these channels to reabsorb sodium. Interstitial nephropathies, post-obstructive uropathy, medullary cystic disease, and the recovery phase of the acute tubular necrosis. Thiazides diuretics causes hyponatremia via number of mechanisms, including polydipsia and diuretic-induced volume depletion. On the other hand, loop diuretics, which are less frequently associated with hyponatremia, inhibit sodium chloride and potassium absorption by the thick ascending loop of Henle. But in doing so, it also blunts the countercurrent mechanism, and this reduce the ability to concentrate urine. So when using loop diuretics, yes, we are losing much more sodium chloride, but we are losing an equal amount of water. With using thiazides, you are losing the sodium chloride, but you are not decreasing the countercurrent mechanism, and so the interstitium is still highly concentrated with maybe 700, 1000, or 1200 milliosmoles in the interstitium, and thus water is still reabsorbed in the collecting duct, and that's why thiazides causes hyponatremia, while loop diuretics, although they excrete more sodium in total, they do not cause or less associated with hyponatremia. Other causes we already mentioned, like glycosuria, ketonuria, such as in DKA or HHS, and bicarbonate such as in renal tubular acidosis or metabolic alkalosis, where the associated bicarbonate urea leads to loss of sodium. There is a special entity called the cerebral salt wasting syndrome, and it's inappropriate natriuresis in associations with intracranial disease, such as subarachnoid hemorrhage, traumatic brain injury, craniotomy, encephalitis, and meningitis. Distinction has to be made between the cerebral salt wasting syndrome and the syndrome of inappropriate AD, as that critical because the cerebral salt wasting will typically respond to aggressive sodium chloride repletion, while the SAAD will not. Hypervolemic hyponatremia, it occurs in cases where there is increase in total sodium chloride, but accompanied by a proportionately greater increase in total body water. Pathophysiology is similar to that in hypovolemic hyponatremia, except that arterial filling and circulatory integrity is decreased due to specific etiological factors, including cardiac dysfunction and congestive heart failure, peripheral vasodilation, and cirrhosis. Urine sodium concentration is typically very low, less than 10 millimoles, even after hydration with normal saline. Of course, because these type of patients, they are just in hypervolemic status, so they whatever water you give them is gonna third space into their lungs, peritone, interstitium, causing edema, peripheral edema, and etc. This sodium avid state may be obscured by diuretic therapy, which means that when we give diuretics, then we might see an increase in this urinary sodium excretion. causative disorders can be separated by the effect on urine sodium concentration, with acute or chronic renal failure uniquely associated with increase in urine sodium concentration. Eovolemic hyponatremia can occur in moderate to severe hypothyroidism with correction after achieving euthyroid state, and secondary adrenal insufficiency due to pituitary diseases. Glucocorticoids exerts a negative feedback on AVP release by the posterior pituitary, such that hydrocortisone replacement in these patients can rapidly normalize the AVP response to osmolality, reducing circulating AVP. The SIAD is the most frequent cause of eovolemic hyponatremia, the syndrome of inappropriate antidiuretic hormone. The generation of hyponatremia in SIAD requires an intake of free water with persistent intake and at serum osmolalities that are lower than the usual threshold for thirst. Four distinct patterns of AVP secretion have been recognized in patients with SIAD, and these are unregulated erratic AVP secretion, and that is seen about a third of patients with no obvious correlation between serum osmolality and circulating AVP. The second one is a failure to suppress AVP secretion at lower serum osmolalities with a normal response curve to hyperosmolar conditions. The third is a reset osmostat with a lower threshold osmolality and left shifted osmotic response curve. And finally, the fourth is the absence of circulating AVP, suggesting either a gain of function or there is an abnormal AVP secreted from another cell, like not the hypothalamus, the magnocellular cells, or the the neurohypophysis. SID are not eovolemic but are subclinically volume expanded. Serum uric acid is often low and consistent with suppressed proximal tubular transport in the setting of increased distal tubular sodium chloride and water transport. In contrast, patients with hypovolemic hyponatremia will often be hyperuricemic due to a shared activation of a proximal tubular sodium chloride and urate transport. Some causes of the syndrome of inappropriate antidiuresis. We start with the malignant diseases, carcinoma such as lung, small cell or mesothelioma, oropharynx cancer, gastrointestinal tract including stomach, duodenum, and pancreas cancers, genitourinary such as ureter, bladder, prostate, and endometrium, endocrine thymoma, lymphomas, sarcomas including Ewing sarcoma. Pulmonary disorders such as infections, bacterial pneumonia, viral pneumonia, pulmonary abscess, tuberculosis, aspergillosis, asthma, cystic fibrosis, and respiratory failure is associated with positive pressure breathing. Disorders of the central nervous system, including infection, encephalitis, meningitis, brain abscess, Rocky Mountain spotted fever, AIDS, bleeding and masses such as subdural hematoma, subarachnoid hemorrhage, cerebrovascular accidents, brain tumors, head traumas, hydrocephalus, cavernous sinus thrombosis. Others such as multiple sclerosis, Guillain-Barré syndrome, Shea-Drager syndrome, delirium tremens, acute intermittent porphyria. Drugs that causes SIAD such as chlorpromide, SSRI, tricyclic antidepressants, clofebrate, carbamazepine, vincristine, nicotine, narcotics, antipsychotics, ifosfamide, cyclophosphamide, non-steroidal anti-inflammatory drugs, Molly, ecstasy, drugs that contain MDMA. All these drugs increases or stimulate release of AVP. Other AVP analogs such as desmopressin, oxytocin, and vasopressin. Other causes include hereditary gain of function mutation, idiopathic transient endurance exercises, general anesthesia, nausea, pain, and stress. Low solute intake and hyponatremia. This occurs in patients with very low intake of dietary solutes, and it happens in patients demographics who are alcoholics and whose whole soul nutrient is beer, and hence the diagnostic term is beer potomania. extreme vegetarian diets, and these type of patients present with very low urine osmolality of less than 100 to 200 milliosmoles, with a urine sodium concentration that is less than 10 to 20 millimoles. The fundamental abnormality is the inadequate dietary intake of solutes. The reduced urinary solute excretion limits water excretion, such that hyponatremia ensues after relatively modest polydipsia. AVP levels have not been reported in patients with biapotomania, but are expected to be suppressed or rapidly suppressible with saline hydration. Primary polydipsia is often neglected as a cause of hyponatremia, and also the text did not mention it, but we have seen it in a case, and it's reported in several studies, so we have found it fit to be put with the causes of hyponatremic hyponatremia. Now we discuss the clinical features of hyponatremia. The symptoms of hyponatremia are primarily neurologic, usually at plasma concentration of less than 125 millimoles. Early symptoms can include nausea, headache, and vomiting. Severe complications rapidly evolve, including seizure activity, brainstem herniation, coma, and death. A key complication of acute hyponatremia is normocapnic or hypercapnic respiratory failure. Normocapnic respiratory failure in this setting is typically due to non-cardiogenic and neurogenic pulmonary edema with a normal pulmonary capillary wedge pressure. Acute symptomatic hyponatremia is a medical emergency. Women, particularly before menopause, are much more likely than men to develop encephalopathy and severe neurological sequelae. The causes of acute hyponatremia can include iatrogenic, such as post-operative premenopausal women, hypotonic fluid which causes with causes of increased vasopressin, lysine irrigation in surgeries of the urethra and prostate, such as TURP and uterine surgery, colonoscopy preparation, and recent institution of thiazides, polydipsia, MDMA drugs, ecstasy, mole ingestion, exercise induced, and multifactorial, such as thiazides and polydipsia. Persistent chronic hyponatremia results in an efflux of organic osmolytes such as keratin, betaine, glutamate, myoinositol, and taurine from brain cells. This reduction in intracellular osmolytes completed within 48 hours, and this is the time period that clinically defines acute and chronic, differentiates between acute and chronic hyponatremia. And this differentiation is clinically important because the rapid correction of chronic hyponatremia, when we don't have these intracellular osmolytes, will cause demyelinosis, leading to osmotic demyelinosis syndrome, known also as the central pontine demyelinosis syndrome. While in the acute status, it's theoretically safer to aggressively replenish and correct sodium concentrations. Diagnostic evaluation of hyponatremia. We have to do a detailed drug history, a careful clinical assessment of volume status. A radiological imaging may also be appropriate to assess whether the patient have a pulmonary or CNS cause of hyponatremia. Chest X-ray is not enough and we have to do a CT chest. Serum osmolality to exclude pseudo-hyponatremia, which is elevated serum protein or lipid. Renal function test. Hyperkalemia may suggest adrenal insufficiency or hypoaldosteronism, as we mentioned earlier. Serum glucose should be measured. Plasma sodium concentration falls by 1.6 to 2.4 millimole for every 100 milligram per deciliter of glucose, but this is a true hyponatremia. Serum uric acid also is important to measure, since SIAD syndrome causes hyperuricemia, and volume depleted patient will be hyperuricemic. Thyroid, adrenal, and pituitary function have to be done. urine electrolyte and osmolality, because a urine sodium concentration less than 20 to 30 is consistent with hypovolemic hyponatremia and the clinical absence of hypervolemia. A sodium avid syndromes. So what it basically means that when we see a urine concentration of urine sodium concentration of less than 20 to 30 millimole, we would it would suggest that this patient is hypovolemic with hyponatremia. Uh, if the patient doesn't have a condition which causes hypovolemia and low sodium excretion, like congestive heart failure or third spacing, such as ascites and liver cirrhosis. A syndrome of inappropriate antidiuretic hormone will typically excrete urine with a sodium concentration that is more than 30 millimole, and defer making a diagnosis of SAED until 1 to 2 weeks after discontinuing thiazides. This is important to note that we cannot diagnose a patient with an syndrome of inappropriate antidiuretic hormone if he's on thiazides, and we have to discontinue them for 2 weeks in order to know if that's a true SID or not. A urine osmolality of less than 100 milliosmol per kg is suggestive of polydipsia. A urine osmolality of more than 400 milliosmols per kg indicate that AVP excess is playing a more dominant role. Intermediate values are more consistent with multifactorial pathophysiology, such as AVP excess, with a significant component of polydipsia. Urine potassium concentration is required to calculate the urine to plasma electrolyte ratio, which is useful to predict the response to fluid restriction. Treatment of hyponatremia. 3 major considerations we have to make in guiding the therapy of hyponatremia, which includes the presence and or severity of symptoms, a chronicity, a risk of demyelinosis syndrome, osmotic demyelinosis syndrome, the response to intervention, unpredictable, because the hyponatremia usually have unpredictable response to treatment. Treatment or withdrawal of the underlying cause is very important, and it is the cornerstone of the treatment of hyponatremia. Water deprivation, and some notes about it. Patients who are excreting minimal electrolyte-free water will require aggressive fluid restriction. This can be very difficult with patients of SID. And why is that? Because that their thirst is also inappropriately stimulated. The urine to plasma electrolyte ratio, which is urinary sodium plus potassium over plasma sodium, can be exploited as a quick indicator of electrolyte-free water excretion. Patients with a ratio of more than 1 should be more aggressively restricted to less than 500 ml per day if possible. Of those patients with a ratio of 1 should be restricted 500 to 700 ml, and those with a ratio of less than 1 should be restricted to less than 1 liter per day. Potassium chloride in hypokalemic patients, potassium replacement will serve to increase plasma sodium concentration, as we have seen earlier in the pathophysiology, that in the principal cells potassium is exchanged for sodium. And sodium concentration. Aggressive repletion of potassium has the potential to overcorrect the plasma sodium concentration even in the absence of hypertonic saline. Oral furosemide, oral salt tablets, 20 milligrams twice a day. Higher doses may be necessary in renal insufficiency and risk of renal dysfunction and hypokalemia. Dimeclocycline is a potent inhibitor of principal cells and can be used in patients whose sodium levels do not increase in response to furosemide and salt tablets. Reduction in GFR, it causes reduction in GFR and should be avoided in cirrhotic patients. Palatable preparation of oral urea has also been used in the treatment of chronic hyponatremia. Also, there is a role for using AVP antagonists such as Vaptans, and they are effective in cases of SIAD and in hypervolemic hyponatremic due to heart failure or cirrhosis. Therapy with Vaptans must be initiated in a hospital setting with liberalization of fluid restriction more than 2 liters per day and close monitoring of plasma concentration. Tolvaptan is an oral drug while Conivaptan is an IV, and we have to restrict them to 1 to 2 months They are used primarily in cases of small cell lung cancer. Treatment of symptomatic hyponatremia. Acute symptomatic hyponatremia, we start with hypertonic 3% saline, which has 513 millimoles, to acutely increase plasma sodium concentration by 1 to 2 millimole per hour to a total of 4 to 6 millimoles. This modest increase is typically sufficient to alleviate severe acute symptoms, after which corrective guidelines for chronic hyponatremia are appropriate. A bolus of 100 ml of hypertonic saline is more effective than an infusion. A sodium plus deficit equal point. Sodium deficit is calculated by multiplying zero point 0.6 of body weight by the target plasma sodium concentration minus the starting plasma concentration. And simply put, because 60% of the body weight is fluid, so we are just multiplying the concentration of the deficit, how much our starting sodium, so let's say it's 125, and let's say that our target plasma sodium concentration is 135. So and the patient whose weight is 100 kilograms, so zero point 0.6 by 100, that's 60, and by 10, that's 600. So a 600 millimole is the total sodium deficiency in this patient, and he should be corrected no more than 600 and over a period of time to not exceed 8 millimole per day. Sodium concentration should be monitored every 2 to 4 hours during treatment. If overcorrection occurs, hyponatremia can be safely reinduced or stabilized by the administration of the AVP agonist desmopressin acetate DDAVP, and or the administration of a free water, typically intravenous D5W. Now, we are done with the hyponatremia, and we will go into the hypernatremia. Hypernatremia is an increase in the plasma sodium concentration of more than 145 millimoles, considerably less common than hyponatremia. It's associated with a mortality rate as high as 40 to 60%, mostly due to the severity of the associated underlying disease process. Usually the result of a combined water and electrolyte deficit with losses of H2O in excess of sodium. Less frequently, the ingestion of iatrogenic administration of excess sodium can be causative, for example, after IV administration of excessive hypertonic sodium chloride or sodium bicarb. Etiologies include a central defect in the hypothalamic osmoreceptor dysfunction with a mixture of both decreased thirst and reduced AVP secretion, loss of water via both renal and non-renal routes. Osmotic diarrhea and viral gastroenteritis typically generate stools with sodium and potassium less than 100 millimoles, thus leading to a water loss and hypernatremia. In contrast, secretory diarrhea typically results in isotonic stool, and this hypovolemia with or without hypovolemic hyponatremia. Renal water loss include osmotic diuresis secondary to hyperglycemia, such excess urea, post-obstructive diuresis, or mannitol. Central or nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus, simply put, it's the renal resistance to antidiuretic hormone, to the AVP, the vasopressin. It can be partial or complete, and there are genetic causes which include loss of function mutation in the X-linked V2 receptor, mutation in the AVP response aquaporin 2 water channel can cause the autosomal recessive and the autosomal dominant subtypes, whereas recessive deficiency of the aquaporin 1 channel causes a more modest concentrating defect. Hypercalcemia can also cause polyuria and nephrogenic diabetes insipidus. Another common acquired cause of nephrogenic diabetes insipidus is hypokalemia, which inhibits the renal response to AVP and downregulates aquaporin 2 expression. Drugs like lithium ifosfamide and several antiviral agents also cause this blunting of effect. Combined therapy within lithium and amiloride can mitigate lithium-associated NDI. Lithium uses ENaC to enter the principal cells, so giving amiloride with lithium will decrease the incidence of or the associated diabetes insipidus. Mesna can be used with ifosfamide to reduce renal toxicity. And there is also a subtype of diabetes insipidus, which is gestational. Clinical features of hypernatremia include altered mental status, which is the most frequent manifestation, ranging from mild confusion and lethargy to deep coma, may lead to parenchymal or subarachnoid hemorrhage and or subdural hematomas, most commonly in pediatric age group. Osmotic demyelination, hypernatremic rhabdomyolysis with chronic hypernatremia more than 48 hours are less likely to develop severe neurological compromise due to accumulation of organic osmolyzed keratin, betaine, glutamate, myoinositol, and taurine, which are the same ones that usually go out of the cell in the chronic hyponatremia. So it's the other way around. It's all cases with the acute changes in sodium causes the most profound symptoms, but with the chronic hyponatremia, we have these organic osmolytes which accumulate inside the cells and somewhat stabilizes them. Diagnostic approach of hypernatremia. History should focus on the presence or absence of thirst, polyuria, and or extrarenal sources for water loss, such as diarrhea. Physical examination and neurological exam and assessment of the extracellular fluid volume (JVP) orthostasis should be done, and accurate documentation of daily fluid intake and daily urine output is also critical for the diagnosis and management of hypernatremia. Measurement of serum urine osmolality in addition to urine electrolytes, and appropriate response to hypernatremia is maximally concentrated urine of low amount, more than 800 milliosmoles per kg, and less than 500 ml per day. Indirect water deprivation test. This test can be performed in patients with hypotonic polyuria without hypernatremia. And so, if an infusion of hypertonic saline increases the level of circulating copeptin, which is a peptide that is co-secreted with AVP, then the patient suffers from polydipsia rather than central diabetes insipidus. But patients with baseline hypernatremia are hypertonic without polyuria, and so water deprivation is absolutely contraindicated in this setting. Simply put, if the patient is at the baseline is hypertonic and hypernatremic, then you cannot absolutely give a hypertonic saline to do the indirect water deprivation test. But if you are having a hypotonic polyuria, then administration of hypertonic saline would cause an increase in AVP secretion that we can detect by increase in copeptin. Daily measurement of urine electrolytes combined with accurate measurement of daily urine volume is also required with the diagnostic and follow-up of patients with hypernatremia. To reiterate the causes of hypernatremia, we have this diagram, and with the stepwise approach to patients with hypernatremia. The first step we have to do is to determine the extracellular fluid volume. If the ECF volume is increased, then we start by administration of hypertonic sodium chloride or sodium bicarb. Now, if the ECF volume is not increased, then we check the urine for tonicity and volume. If we have a minimal volume, meaning less than 500 ml per day, and maximally concentrated more than 800 milliosmoles, then the cause is a probably insensible water loss, gastrointestinal water loss, or remote renal water loss, and the treatment here, of course, is to replenish that water with D5W or hypotonic saline. If not, if the urine is not minimal in amount and it is not maximally concentrated, then we have to check the urine osmolality excretion rate. Is it more than 750 or not? So if it is more than 750, then it's usually diuretic or osmotic diuresis, so DKA, HHS, or use of thiazides, Lasix, and etc. Now, if there is no the urine osmol excretion rate is not more than 750 milliosmoles per day, then we give the patient desmopressin. If he has urine osmolality increase, then this is simply a case of central diabetes insipidus. If not, the urine osmolality is unchanged, then this is a case of nephrogenic diabetes insipidus. As we have mentioned earlier, the cornerstone of the treatment is the treatment of the underlying cause of hypernatremia, and that should be withdrawn or corrected, whether it is drugs, hyperglycemia, hypercalcemia, hypokalemia, or diarrhea. It is imperative to correct hypernatremia slowly to avoid cerebral edema, typically replacing the calculated free water deficit over 48 hours. The plasma sodium concentration should be corrected by no more than 10 millimole per day, which is about similar to the rule with hyponatremia. A rare exception is patients with acute hypernatremia due to sodium loading who can safely be corrected rapidly at a rate of 1 millimole per hour, so giving us 24 millimole per day. Water should ideally be administered by mouth or nasogastric tube as the most direct way to provide free water. We can also give the 5W IV or hypotonic solutions. We can also give synthetic AVP, DDAVP in cases with central diabetes insipidus, but patients with nephrogenic diabetes insipidus due to lithium, we can maybe treat that with amiloride 2.5 to 10 milligrams per day, thiazides inducing hypovolemia and increasing proximal tubular water resorption. So thiazides is also a good treatment for hypernatremia because it causes loss of sodium chloride without decreasing the water content. NSAIDs also can be used to reduce the negative effect of intrarenal prostaglandins on urinary concentrating mechanisms, but it must be emphasized that thiazides, amiloride, and NSAIDs are only appropriate for chronic management of polyuria from nephrogenic diabetes insipidus and have no role in the acute management of associated hypernatremia. We have talked about the management of hypernatremia and replacement of water deficit. Now we are going to explain how we are going to calculate water deficit and how we are going to administer that amount. So the first step is to estimate total body water, and we do that by multiplying 50% of body weight in women or 60% in the cases of men, and then we calculate the free water deficit by subtracting the patient sodium level from 140, which is the median for sodium level, dividing that by 140 and multiplying it by total body water. So for example, let's say we have women whose body weight is 100 kilograms, so she has a total body water of 50 liters in the normal state, and here sodium level is 154. So 154 minus 140, we have 14. 14 over 140 is 0.1, and 0.1 multiplied by 50 is 5 liters. So she now has 45 liters, and her deficit is 5 liters of water. Administration of deficit should be done over 48 to 72 hours without a decrease in plasma sodium concentration more than 10 millimoles per 24 hours. So we have about 10 pints of normal saline that should be given over 48 hours, so 5 pints per day, or not normal saline, D5W, or hypotonic saline, or more appropriately free water by NG tube or oral route. Now, ongoing water losses, because we have already determined how much the patient has a deficit, now we have to determine how much she's already losing, because we have to replace the 5 liters of free water plus whatever she is clearing per day. And To do that, we have to calculate the free water clearance, and in order to do that, we have to have the volume of the urinary volume. So let's say she excretes about uh, 1 liter per day of urine, and then we calculate the urinary sodium, add that to the urinary potassium, divide it by the plasma sodium, and subtract it from 1. So let's say we have a plasma sodium of 150, and then we have a urinary sodium of 30 and urinary potassium of 20, which is, I think, overestimation of the urinary potassium. I think it should be around 5 or something like that. And then we have 50 divided by 150, which is 0.3. So we have 1 minus 1.0.3, which equals zero point 0.7 multiplied by 1 liter, so that adds 700 ml of free water clearance. And the idea that we calculate the electrolytes, because we need to replenish only free water, so she's already excreting some sodium and some potassium. And if we calculate the other 300 ml, we might be overestimating the free water loss and induce hyponatremia or a rapid correction of hypernatremia that we don't want in this case. We add also to that 100 ml per kg per day, less if ventilated, more if febrile. So we said she has 100 kilograms, that would be 1 more liter, and then we add the component. So we have 5 plus 700 plus 1 liter, we have 6.7 liters to be corrected over the period of 48 to 72 hours, so about 12 to 13 pints, or more accurately 13 pints per 48 hours. And with that, we conclude our lecture about sodium disturbances and water disturbances.